in your needs, sure.
All right. Well, happy Wednesday. Yeah, I like Wednesdays, middle of the week. Fun, we get to go to lab, good times. Remember on Friday, and I already heard some of you discussing that you'll need to choose what type of game you're going to do. It can be very, it doesn't have to be very specific. It can be pretty broad, board game, card game, video game, whatever you decide, you can submit that. And then also on Friday, remember if you wanted to submit corrections for your exam, those are due on Friday as well. And they have to be either handwritten or on paper, not submitted electronically. So those corrections will be due on Friday. I think that's it. Okay, so on Monday, we talked about listeria, one of the gram-positive rods. Today, we'll talk about another gram-positive rod, and this is one that we will be potentially identifying in some of you, maybe. We are using the growth media to isolate this particular bacterium in lab today as we do the oral or upper respiratory and skin microbiome. Corynebacterium diphtheriae is one that could be potentially in there. So Corynebacterium diphtheriae is the cause of diphtheria, the disease diphtheria. Just like listeria, they are kind of these short gram-positive rods. But remember I told you one way you could distinguish under the microscope between listeria and diphtheria is that the diphtheria bacterium is a little bit more irregularly shaped. So some of the rods could be smaller, some of them could be a little bit longer, maybe a little bit fatter, a little bit skinnier. And sometimes when you have these short rods, the other term they might use to describe them is called coccobacillus, like it's a mix between a coccus and a bacillus. So if you describe them as coccobacillus, that's okay too. Both listeria and diphtheria, because they're these short rods, are sometimes called coccobacillus. On a plate, they should form rather large colonies. And this is a bacterium that is found worldwide, but we tend to see relatively low rates in countries that have high rates of vaccination. So the diphtheria vaccine is readily available. It's the D of Tdap or DTaP. But we'll talk about in just a minute why people would still carry the bacterium even if you are vaccinated and you wouldn't have any symptoms of disease. So this was a headline from a few years ago. It was the first case of diphtheria in Spain since 1986. And I want to say when I pulled this headline, it might have been 2018 or 2019, so it had been more than 30 years since Spain had had a case of diphtheria. It was an 8-year-old boy who died of diphtheria because the parents thought, we don't need to vaccinate anymore. Okay, and unfortunately, they learned a very hard lesson that it is still important to vaccinate. And so the reason that some people might carry the bacterium in their upper respiratory tract but not experience any symptoms of disease is because the symptoms of disease are actually caused by the production of a toxin. And not every strain of Corynebacterium diphtheriae produces that toxin. So the toxin is found in strains of the bacterium that have been infected by a bacteriophage. So the bacteriophage itself actually carries the toxin gene, and that's what can allow the formation of the disease symptoms. And really all of the disease symptoms of diphtheria are mediated by the toxin. So the vaccine itself is actually a vaccine only against the diphtheria toxin, not against the diphtheria organism itself. So the bacterium itself is not a problem. It's only when it produces the toxin that we have a problem. And so you see, that's what they're trying to illustrate here. You have a bacteriophage that's infected the bacterium, and now it can produce the diphtheria toxin. And the specific type of toxin that's produced is called an A-B toxin. Lots of toxins do fit into this category of A-B toxin. So generally what you'll have is one or more B domains in the toxin. B is binding. B is the domain that binds to the host cell. The A domain, usually there's only one, so there might be multiple binding domains, but there's usually only one A or active domain. That part of the toxin, the A part, will do the action in the cell that causes whatever effect we're going to see. And in the case of diphtheria toxin, what happens is the A domain of diphtheria toxin interferes with protein synthesis. So in eukaryotic cells, if we think about the process of translation, so you have initiation of translation, and then you have elongation. And elongation requires accessory proteins to come in and to help add the new amino acids to the growing polypeptide chain. What the toxin does is it interferes with elongation factor 2, which is an important one for protein synthesis. And that causes the cell to die. If you can't make proteins, eventually you will die. It binds to a specific receptor on our cells, heparin binding epidermal growth factor. For me, it's not terribly important that you remember exactly which receptor it binds to, but it is important to note that it is found on lots of eukaryotic cells, particularly those of the cardiac system and nervous system. So those are going to be parts of the body that we worry might be affected when a patient has diphtheria. We worry about cardiac and nervous system complications. Generally, patients who do develop diphtheria develop a respiratory disease, and symptoms will result 2 to 4 days after exposure. What you're looking at in your patient is they're going to feel tired. That's malaise, right? They'll have a sore throat, and they have the production of what's called an exudate. And you can kind of see it back here in this image, and then right here, this big patch of yellowish material. And they call it a pseudomembrane. It looks a lot like the color and the texture. Just by imaging, it looks a lot like what you might, patches you might see when a patient has strep throat. But this is not a pocket of infection. It's a pocket covering basically an open wound. So if you try to scrape off that pseudomembrane, it will be raw and may bleed. And the really dangerous thing about this is it can form on the epiglottis and cause the patient to suffocate. And some patients may develop a symptom they call bull neck, so the neck will swell because of the actions of the toxin. So if a patient comes in, they have that pseudomembrane, you only see a pseudomembrane in diphtheria. But if you're is it a pseudomembrane or is it strep throat pockets, if their neck is swollen, it's definitely diphtheria, so bull neck. And as you might imagine, because the toxin can bind to those receptors that are found in higher numbers, maybe on cardiac and nervous system cells, you can have cardiac complications and neurotoxicity. If the bacteria get into a wound, you can also get a cutaneous form of diphtheria. And so it's kind of hard to see, but in this part right here, it looks like they've kind of scraped off the pseudomembrane, and it's just raw tissue under there. It's destroying the top layers of tissue because it is a toxin that causes cell death. So, 2004, last patient, the numbers have changed, but that's okay. Last patient with respiratory diphtheria seen in the US, an unvaccinated 63-year-old man developed a sore throat while on a week-long trip in rural Haiti 2 days after he returned home to Pennsylvania. He visited a local hospital with complaints of a sore throat and difficulty swallowing. He was treated with oral antibiotics, but returned 2 days later with chills, sweating, difficulty swallowing and breathing, nausea, and vomiting. Remember, the symptoms are caused by a toxin. So if the antibiotics are not effective, or if there's already so much toxin in the body, you can still experience symptoms because of the presence of the toxin. He had diminished breath sounds in his left lung. He had pulmonary infiltrates and enlargement of the epiglottis. there aren't a ton of infections that will cause a swelling in the epiglottis. There are a couple. Diphtheria is one. We'll talk about another. But in terms of like the gram-positive rods, diphtheria is the only one I can think of off the top of my head that's going to do that, swelling of the epiglottis. Yellow exudate on the tonsils, back of the throat, the soft palate, admitted to the ICU and treated with a whole bunch of antibiotics, steroids. Over the next 4 days, he became hypotensive, so super low blood pressure with a low-grade fever. Cultures were negative by the 8th day of illness. Chest x-ray showed infiltrates in the right and left lung, and a white exudate consistent with the Corynebacterium diphtheriae pseudomembrane was observed like around the tongue, epiglottis, all in there. Cultures were still negative. PCR for the exotoxin gene was positive. Despite aggressive therapy, the patient continued to deteriorate, and on the 17th day of hospitalization, he developed cardiac complications and died. This patient illustrates the risk of an unimmunized patient traveling to an endemic area, the classic presentation of severe respiratory diphtheria, the delays associated with the diagnosis of an uncommon disease, and the difficulties most laboratories would now have isolating the organism in culture. If you are not expecting a patient to have diphtheria, because people shouldn't have diphtheria in the United States, it's very unlikely that you'll think about it.
Professor?
Yes.
So if he was, for example, if the patient was treated on that day, the day he goes to the hospital and they just give him the antibiotics, so he wouldn't face all this issue or no?
Well, they did give him antibiotics when he came to the hospital, but since he was already having symptoms, that means the toxin was in there. So they probably, instead of doing oral antibiotics, needed to admit him to the hospital and do IV antibiotics.
So the hospital didn't find out on the right time that he had this disease?
Yeah, they didn't find out early enough because the cultures can be negative. And a lot of labs don't know how to culture it anymore because you have to have special media to look for it. And if you don't think that that's what you have, you're not going to test on that media, so you're not going to look for it. Yeah, and so, I mean, I can't say for sure. I mean, as I get older and older, 63 doesn't sound that old. But you know, he may have had other health complications that could have, you know, made it more difficult for him to recover, but he would have had a much better chance if they had started him on those really strong antibiotics earlier. Yeah. Yes.
So this one's not like I think it's like S. aureus, where like if the toxins in the body, if you test like the site where like you can tell that something's going on, that they won't be able to find it there. Does that make sense? So
you can sometimes, if I'm understanding correctly, and so if my answer doesn't make sense or answer your question, please let me know. If they use the right growth media and the right growth conditions when they test that area, maybe where the pseudomembrane is or that upper respiratory tract, theoretically they should be able to find it.
Okay.
But because it's so rare, it's so uncommon, they don't know how to test for it or they don't think to test for it. And so that's how it can sometimes slip through the cracks. But at this point, I mean, and you have to think about kind of what was going on socially. At this point, people were all still getting vaccinated pretty heavily. There wasn't this huge anti-vaccine sentiment like there is now. So now I would think more clinical professionals will start to think, you know what? Maybe it's diphtheria because people are not getting vaccinated as frequently as they should anymore. Yeah. But you have to culture it. It's a little bit more fastidious, and so you have to culture it on specific media, and we'll be using that today. So it can be diagnosed by culture if you culture it under the right conditions, which again we'll talk about today. But you see they found the toxin gene based on PCR. So even if you can't grow the organism, maybe you suspect diphtheria and your lab doesn't have that media, you don't have time to order it, you could run a PCR instead and look for the toxin gene or other biochemical assays. But that pseudomembrane is pretty unique. It's the only infection that does that. And then combined with that possibility of the bull neck, the symptoms are pretty diagnostic there. Treatment of early infection, the other thing that they could do if they suspect diphtheria and the patient doesn't seem to really be improving, is give a patient diphtheria antitoxin. So basically the passive immunization, the preformed antibodies against diphtheria. The antibiotic therapy that generally will work, penicillin or erythromycin, but of course we want to prevent infection as much as possible, so you should be immunized with the diphtheria toxoid. And that, again, is part of the DTaP or DTaP that they recommend you get every 10 years or so. Okay. So how many of you know about the Iditarod? You've heard of the Iditarod, the dog sled race in Alaska. So the history of the Iditarod is not just it's fun to race with big floofy dogs, but it's that in 1925, in Nome, Alaska, which is up here, really, really close to the Arctic Circle, in January, all of the kids in Nome got diphtheria and people were dying. This was pre-vaccination. It was 1925. So what they would do for people who had diphtheria was give them anti-serum. So there was diphtheria anti-serum. So if a patient got diphtheria, if they were diagnosed early enough, they could be given serum to help reduce the symptoms and help them clear the infection. Now, in Nome, they ran out. The nearest shipment or the nearest available anti-serum was in Seattle. So if you picture the geography, you know, Alaska's way up here, you have a whole mess of Canada, and then there's Seattle. And this is all covered in ice and snow. In 1920s, you weren't flying there. You weren't driving there, and you weren't taking the train. So how did you get there? By dog sled. So, how do you get, you don't need to take a dog sled from Seattle to Alaska, but you're not flying, you're not taking a train, you're taking a boat. And so they shipped the serum to this town here called Seward in Alaska. And this part of Alaska, even when it's Alaska cold, it doesn't freeze. So they could get ships into there, but they can't get ships up here because it freezes. So they have they had some train tracks that were able to go. You can see here's the train tracks. This is where they actually started, and then they used dogs and dog sleds to get the serum from here to Nome to try to stop the outbreak. So if you've ever seen the movie Balto was one of the dogs that was like the lead for one of the major legs of that journey. So now they do the Iditarod, which follows some of the same path. They do it every year to kind of honor that tradition. And so I went to Alaska when I was able to have fun before I had kids. I went to a conference in Anchorage, which is right here, and we went down to Seward, mostly because I wanted to go whale watching and look at birds, but they also had this place where you could go look at the dogs. And so they celebrate the trail, and you know they have all these things where they raise dogs. This place raises dogs to do the Iditarod, and I tried to smuggle the puppy, but they would not let me. They will sell you these puppies after they've been trained, and they cost like tens of thousands of dollars. So you can get them to run a dog sled. Apparently, depending on their personality, where they go, right? If they're leaders, they go in the front. If they're, you know, real strong, they go in the back. And if they're just kind of derpy, you put them in the middle. And then they let you, because it was summer, right? They let you go on the dog sled. So they'll pull you on a wheeled cart instead. But this is all to celebrate. The whole reason for this is because of diphtheria. So prior to vaccination, you had to depend on anti-serum. And so they run the Iditarod, they do all these dog sled races to celebrate and honor that. So if you ever go to Alaska, you can go play with the dogs. So I would totally recommend it. I would go back to Alaska when my kids are older and have them do it. It was really fun. Okay. Questions about listeria or diphtheria before we move on to the acid-fast bacteria? Watch Balto, plan your trip to Alaska. Actually, a really cool place. So I was glad my conference was there because it was partially a free trip because it was for a conference. Okay, so in this section, we'll talk about the acid-fast bacteria. So acid-fast bacteria are a little bit different. We don't classify them as gram-positive or gram-negative because they don't stain appropriately with the gram stain.
It's already there, Professor?
Huh?
The slides are already there?
They should be. Are they not? Oh, I'll put them. I probably uploaded them and then didn't publish them because that's how I roll. Let me do it right now. I'm like, I'm so ahead. I did, yeah, close. So close. Okay. Almost. But anyway, so they're called acid fast because they have surrounding their cell wall, okay, it should be published, this really kind of thick layer of this type of acid called mycolic acid. And it's almost like a waxy layer that surrounds the bacterium. So what they're trying to illustrate in this cartoon here, here's a gram-positive, classic gram-positive. We have the one phospholipid bilayer surrounded by a thick layer of peptidoglycan. It has the lipoproteins, the teichoic acids. In the middle is your gram-negative, where you have the two membranes and a very thin layer of peptidoglycan. And you have the LPS. Remember, LPS is super important for gram-negatives. And then you have the bacteria that we call acid-fast. So you have only one membrane, so sort of like a gram-positive. You have a really thin layer of peptidoglycan, so sort of like a gram-negative. And then you have all of these mycolic acids on the outside. And so it just won't stain appropriately with a classic gram stain. As far as we know, there are only 5 genera that belong to this group of being acid fast. 2 are more important causes of human disease. They also are non-motile, they're non-spore forming, and they're aerobic. The first genus that we'll talk about is Mycobacterium. They're very creatively named. Mycobacterium, they're acid fast. They have mycolic acids with anywhere from 70 to 90 carbons. Different genera can have different numbers of carbons. And so they have that lipid-rich cell wall because it's that waxy layer. And what you see in this picture is what sometimes colonies can look like on a plate. And those proteins that are embedded within that waxy layer really stimulate the immune system. They're potent immunogens. We can classify this genus kind of even further into 2 broad categories of slow growing and rapid growing. We can also separate them based on the production of pigment. And so what we'll talk about first are 2 really important slow-growing Mycobacterium. The first is Mycobacterium tuberculosis. So this is the bacterium that causes the disease tuberculosis. What happens with tuberculosis, this is a respiratory infection. So when you have a situation where a person has tuberculosis, they'll often, especially when they have active tuberculosis, they'll be coughing, and as they cough, the bacteria get into the air, right? And they can be inhaled by another patient. So it can be, when I was in Fresno, there was a case at Fresno City College, and everybody was like, because one of the students at Fresno City College had tuberculosis. And around the same time, a student at a high school in Kansas had it, and 33 of the classmates got it. It's pretty contagious if you can give it to 33 different people. When it gets into the host, it is one of those bacteria that actually wants to be phagocytized. So it can avoid the immune system by being internalized by macrophages. What happens in the body is you have all these infected macrophages, and the body doesn't really know what to do with it. Your body's like, we have this infection. The infection is inside the cells we normally use to get rid of the infection. So what we're going to go ahead and do is just pretend like it doesn't exist. So they build a wall around it. Because if you build a wall surrounding your problem goes away. Yeah, your problem doesn't go away. You just now have a problem hidden behind a wall. So they use other immune cells to wall off infected macrophages. And those pockets are called granulomas. And you can see them on an X-ray when a patient has tuberculosis. I am not a medical doctor, obviously, and I am really terrible at interpreting X-rays. So hopefully those of you who actually become medical doctors will be much better at it than me. But you can see them on the X-ray. Take my word for it. But eventually, as you might expect, when you sort of haphazardly throw together a wall to pretend your problems don't exist, the wall can fall apart. And when the wall falls apart, the bacteria can spread. So you can eventually get necrosis. They call it necrosis of the granuloma. That pocket, that walled area where the body tried to protect itself from these infected macrophages, it falls apart, and the bacteria can be released to go infect new cells. Okay. And that cycle can just repeat itself over and over and over again. In the US, we don't always hear a ton about tuberculosis, which is kind of a shame. It's actually relatively common in the US. It is not nearly as common in the US as it is in other parts of the world. It is one of the most common infectious diseases worldwide, and estimates are that about 1/3 of the worldwide population is infected. 1/3 of the US? No. Of course not. But in places where tuberculosis is endemic, yes. And in some of those places, we also do see a high rate of co-infection with HIV. It's most likely that HIV suppresses the immune system just enough that it makes HIV patients that more susceptible to the infection. So this is the most recent data that the CDC has from 2021. They list all of the states and then some of the major cities. The darker the state or city is colored, the higher the incidence of infection. So those of you who might be interested in public health, incidence of infection is important. You're looking at the number of TB cases per 100,000 people. So if you have 100,000 people, how many of them have tuberculosis? In the US, it's pretty low. The national average is 2.4. So between 2 and 3 out of every 100,000 people would have tuberculosis in the US. So that's our national average. The states that are the darkest and the cities that are the darkest, so all of those major cities, Baltimore, Chicago, DC, Houston, LA, New York, Philadelphia, San Diego, San Francisco, states like New Jersey, Washington, Alaska, Hawaii, California, Texas are all higher than that. So those states are all higher than the national average. The states in the second darkest color are below the national average, but higher than the target. The target is by 2025, the CDC wants to see 1.3 people or fewer out of 100,000 having the infection. So those are people that are below the current average, or states that are below the current average but higher than the target. And then any of the states that nobody wants to live in, I'm just kidding. I kid. Any of those states that are the lightest color are already below the CDC target. But I mean, it kind of makes sense when you think about it. Tuberculosis is endemic in lots of countries worldwide. in countries that have higher rates of tourism, or in states that have higher rates of tourism, of immigration, of population density, you're going to have higher incidence of pretty much every disease, but tuberculosis in particular. So it's not a surprise that places people like to go have more disease because there's so many more people there. Okay. And then I'm not going to do the math because it's Wednesday and my brain hurts, but you could scale that all the way up to, how many people in the US are actually infected out of the 330 million people that live here. I do have the numbers for you for our state. So there are a number of diseases that we call reportable or notifiable diseases, that if a patient turns up to any healthcare provider and has that infection, the healthcare provider is mandated to report most often to the county reports to the state, and the state reports to the CDC. So those are nationally notifiable or nationally reportable diseases. Anthrax is, I think, so far the only one that we've talked about that is that. Maybe diphtheria and listeria too, but for sure tuberculosis. So not every, you don't have to report a staph infection to the CDC, they don't care. But when you turn up with anthrax or tuberculosis, they do care. So these are the state numbers. All of the counties in white reported fewer than 5 cases. Again, you're looking at some of the least population dense counties, not all, but some. The national average, so counties that are below the national average are in blue. We are in blue. Counties that are above the national average but below the state average are in yellow. And then countries that are above the state average are in red. So the state average is 4.5 cases per 100,000. So the state average is twice as high as the national average, or close to twice as high. So we have a higher proportion of tuberculosis cases in California than nationwide. And then the red counties are where you have the most. So it's estimated that approximately 2 million people in California live with tuberculosis. About 26,000 of them live in Stanislaus County. In California, there were 1,700 new cases in 2021, 10 in Stanislaus County. We're not terribly population dense. We are not, the height of tourism. Again, it's not expected that we would be really high. Okay. So with clinical disease, like we saw on the previous slide, tuberculosis most commonly infects the lungs. But this is a super slow growing bacterium, like super slow. A colony on a plate of this can take 3 to 4 weeks to appear. So you can have it take a year or more for disease to develop after exposure, and then infection can last for years and years. X-rays are the most useful diagnostic tool. So this X-ray on the right-hand side, it looks like, I don't know if this is, I think this is probably supposed to be the left of the patient. So the X-ray is on the right of the screen, but the left lung of the patient is full of infection. When a patient has active tuberculosis, like they have the bacteria actively replicating, they have those granulomas that may have burst, you'll have blood-streaked sputum and tissue destruction. And when you have tissue destruction, the bacteria can spread throughout the body, and they can cause granulomas to form in other parts of the body as well. This is, I think, a cross-section of a liver where there's pockets of granuloma that have formed in there too. So it's a dangerous infection. Well, how is it diagnosed? The most common test that people will take to test for tuberculosis is called the tuberculin skin test using a purified protein derivative, or PPD. Have any of you had that done? Yeah. So if you, I was a substitute teacher after I finished my bachelor's, so I had to get it to work in the school district. I didn't have to get it to work here, but I had to get it to work in the K-12 schools. If you work in a healthcare setting, you probably had to get it. What they do, oh, I have a picture. Okay, so what they do is they take some purified proteins from tuberculosis and they inject them like just under the skin. And so if you actually watch them do it, which I don't know why I did because it creeped me out, but your skin will kind of bubble up when they do it. And then you're supposed to come back in like 48 to 72 hours for them to read your results. And the way they read your results is literally with a ruler. And they're looking for how swollen are you from the site of infection or from the site of an injection. And what that tells them is if it's big and swollen, you had an immune response to that protein. You had memory of seeing tuberculosis before. That's all it tells you. At some point, you were exposed to something related to tuberculosis. If you're negative, you're negative. That's pretty easy. Okay, go home. Okay, but if your PPD test is positive, there's a couple of different options. One, you have a primary active infection. Two, you have a latent infection. Three, you've been vaccinated. People who were born and have lived in the US their entire lives are almost never vaccinated against tuberculosis. So that's, if you're positive, that's a sign that you might be having, a latent or an active infection. But people born in other countries sometimes do test positive simply because they were vaccinated. So they have that memory and they will show up as having an immune response. There is a second generation test that can apparently differentiate between the two. Usually what they would do if you turned up positive is they would send you for an x-ray. If you have granulomas, if you have lung issues, they're going to treat you for tuberculosis. If your lungs are clear, they're going to assume you've been vaccinated or maybe you cleared an infection years and years ago, and they'll let you go on your way. Okay. You can do microscopy of clinical samples. There is a very particular type of staining technique, acid-fast staining, that allows you to stain for the microorganisms. You could do fluorescence microscopy looking for antigens. The skin test is pretty common and it's relatively easy. Culture and nucleic acid-based tests are available, but as I mentioned, culture is tricky because it's so slow. Like you're waiting weeks sometimes for a colony to show up on a plate. There are other techniques like mass spec, things like that, where you can look for byproducts of bacterial metabolism that are a little bit more rapid. Pretty much anything is more rapid than waiting 4 weeks to figure out if a person has TB. So they can provide a rapid and accurate diagnosis. In terms of treatment is complicated by antibiotic resistance. So if tuberculosis didn't sound scary enough, we have multi-drug resistant and extremely drug resistant tuberculosis. Multi-drug resistant tuberculosis, that is if the organism is resistant to 2 or more Mycobacterium specific antibiotics. So there are a couple of antibiotics that are very specific against Mycobacterium because Mycobacterium have that crazy mycolic acid cell wall. Right? That provides a target that you could use and exploit. So if they're resistant to those, they're considered multi-drug resistant. If they're resistant to those and other things, they're considered extremely drug resistant. And extreme drug resistance is on the rise. Part of the reason that we see a lot of drug resistance is because patients don't comply with antibiotic therapy as prescribed, because a normal course of antibiotics for someone who is otherwise healthy and does not have a complication of an extremely drug-resistant infection is 6 to 9 months. So you need a patient to take their antibiotics every single day at the appropriate time for 6 to 9 months. People can't be bothered to take their birth control regularly. They're not going to take their antibiotics regularly. People can't, you can't drink, right? There's a lot of stuff you can't do when you're taking antibiotics, and when you have to take antibiotics for that long, compliance wanes a little bit. So that's tricky. So if you are a physician and you have a patient with tuberculosis, it's really important that you emphasize to them that they have to comply, or they're going to be taking antibiotics for literally years. There are drugs available that patients can take if they've been exposed to prevent the establishment of infection. And there is a vaccine that's available in countries that are endemic. There are debates about the efficacy of the vaccine, but it is available. I think they say the efficacy is relatively low, like something 70%. But I'm like, well, if I have a 70% chance of not getting tuberculosis and I live in an area where everybody else has tuberculosis, I'm going to take the vaccine. I'm going to take that chance. Right? Those are decent enough odds. This was the headline from when I was at Fresno State, hundreds possibly exposed to tuberculosis at Fresno City College. But again, it comes and goes. And this is one of the few infections where you can be forcibly detained if you do not seek treatment and do not comply with treatment. There's a lady, I think in Washington, who they keep having to arrest, and there's always like a new headline. Oh, we just arrested the tuberculosis lady again because she won't seek treatment. She's just like, no, I'm fine. I'm gonna go out in public with my extremely drug-resistant tuberculosis. I'm gonna get on a plane. I'm gonna do what I want. So they can detain you. So drug-resistant tuberculosis in the U.S. Considered a serious threat level. Not a ton of cases back in 2017. Some deaths, kind of expensive. But of course, if more and more people are getting these drug-resistant infections, it could become a more significant problem. So if you do end up with a patient that has tuberculosis, just really insist that they comply with therapy. Questions about tuberculosis? We'll get through one more slow growing and then we'll stop for today. The other slow growing Mycobacterium that is relatively-ish common is Mycobacterium leprae. This is the cause of leprosy. It is not super common in the US. It does exist. There is one reservoir host, armadillos. So, no touchy the armadillos. They're cute, like they really are, but no touch. They could have tuberculosis, or leprosy, excuse me. They could have leprosy. There are a couple of different manifestations of disease, and it depends more on the immune response to the infection, like which type of disease you'll get. There's tuberculoid leprosy, where you have these kind of plaques on the skin. That's what they're showing in the left image. You'll have peripheral nerve damage, complete sensory loss, and visible enlargement of the nerves. The infectivity here is low. It's hard to spread this from person to person. The other type of leprosy is leprodermatous leprosy. Lots of bumps and lesions all over the body. Extensive tissue destruction, nasal cartilage, bones, ears, so fingers, toes, ears. Diffuse nerve involvement with patchy sensory loss, lack of nerve enlargement. You have these macrophages they call foamy. They have a lot of vacuoles in them. Not a lot of lymphocytes involved. You have high levels of IgG, and it is more contagious. So I thought these headlines were, this one especially. Armadillos are infecting humans with leprosy, but we gave it to them first. So that's what the hypothesis is, that actually we gave leprosy to the armadillos and now they just give it back. And this is a very recent headline that I included because now they think leprosy is actually endemic in Central Florida. That it's just and when we talk about epidemiology, the term endemic, we mean that it's always present at low levels. So it's never gone. You're generally probably not going to see a big spike, but it's constantly there. So if you find yourself practicing medicine in Florida, don't, but you could have patients that have leprosy. And then this is an armadillo. So I say no touchy the armadillo, and it sounds like obviously I'm not going to touch the armadillo. People touch the armadillos. So this is one that when I lived in San Antonio, we were going hiking and we saw it dead on the road. That's how you typically see them, because they run across the road, they see a car, and they jump straight up in the air, and then they get nailed and lay on their backs. And when we were coming back from hiking, somebody had put a can of Lone Star beer in its hands. I'm like, man, poor armadillo. So of course I'm like, stop the car. I got out and I didn't touch it. I took a picture. Steve, don't touch the armadillo. But I'm figuring probably the empty beer can is why they thought it was a good idea to touch the armadillo. Okay, questions about leprosy. Okay. Again, we do sometimes see leprosy in the U.S. still. It used to be a lot more common, and they had what were called leper colonies. So we even had a leper colony in the U.S. where they would try to isolate everybody that had leprosy to prevent it from spreading. Now they'll also sometimes call it Hansen's disease. So Hansen's disease or leprosy, that's the same thing. Okay. All right, then I will see you all in about 10, 12 minutes or so in the lab. So grab something to eat, get something to drink, and we'll pick up with the acid-fast bacteria on Friday.